Bonjour, bonjour, and welcome back, everyone. It's a delight to be here with you this evening. My name is Dr. Krista Kostroman, and I have the privilege and pleasure of supporting both the clinic and the science here at the DNA Company. And tonight we get to dive into both of these matters with the wonderful, wonderful Dr. Stephanie Nielsen here today. And our topic is one that is, I'm sure, a conversation held in many households or maybe avoided in many households. So as we know, the rates of cancer of late are on the rise. I talk about over the past decade, where we're seeing year over year an increase in early onset cancer, early onset meaning you're younger than 50 and you're being diagnosed with cancer. And then more recently, since pandemic, we're also seeing a generalized uptick in the number of cancer cases diagnosed. So this evening, what Dr. Steph and I would like to do is talk about what we do about that, knowing these are all on the rise. How do we manage that? And we're going to span all the options from being an ostrich, sticking your head in the sand and pretending it doesn't exist, up to how do you sincerely go about getting an accurate picture of your risk? And heaven forbid, should something like that happen, what are the next steps, especially from that monitoring perspective? So, Dr. Steph, welcome. It's such a delight and a pleasure to have you here.
Thank you. I always love hanging out with you and getting to chat about the things that get us so excited and how we can help others to really live their best lives.
Yeah, it's a true delight. I think I learn something from you every time we're together, and that tickles me. That tickles me, and I'm grateful we get to do that with other people. So I think you and I, why don't we go about this? If the end truly is, let's help people plan, or let's help people get their heads around what do they do about all these scary cancer numbers, right? We don't want people to be scared. We want to give them actionable tools as to this is the reality of the world. Cancer's on the rise. So what do we do about that? Right. So I wonder if we could offer maybe, a few case studies, a few examples of people and how you would suggest clinically interacting with them, right? From the extremes of ostrich, don't gotta do anything, up to here's absolutely everything that you can be doing, right? Does that sound good?
That sounds wonderful.
Lovely. Okay, so why don't we consider first and foremost, we have a female, right? Female, she's in her mid-50s, let's say, just kind of at the tail end of navigating menopause, right? And remarkable health, maybe a little bit of extra weight, coming from menopause, nothing specific, maybe a bit of fatigue, that happens. She herself does not have a history of cancer, but maybe on her mother's side, there is a history of breast cancer. Okay, and so she comes to you and she says, hey, here's the lay of the land. What do you suggest? What are your first thoughts? And again, specific to cancer, I'd imagine you have many other thoughts too.
Well, so specific to cancer, if she comes in and says, my mother's had cancer, my sister's had a cancer scare, I'm afraid for me, what options do I have? And the first thing I'm going to say is, have you done your DNA 360? Because we want to look at genetically, are you predisposed for inflammation? Genetically, do you clear toxins? Genetically, do you build up estrogen? Is your estrogen pushed down the right way? So part of the reason after 35 years of practice that I added functional genomics was because if I'd had that DNA layout early, that would have been like so much easier. Many of the people who follow us know that I had cancer at 21. Well, couldn't figure out why I had all that chronic inflammation. But if I had understood how I don't detoxify, I would have done that much, much earlier. So we can look at estrogen toxicity, we can look at hormone balance, we can look at. So the first thing I would say is that. My second thing that I would say is, again, looking at their personality, looking at their history. Are you someone, obviously, if you're here, you want to be proactive, but how much information do you want? Do you want to know, here's my risks and here's what I do with lifestyle and, supplementation and whatever? Or is it, I want to dig in and scrub out everything and then, I want to know to the last detail? Because I find that analysis leads to paralysis. Some people get a lot of information and they do nothing. And some people get information and they dive head on in, but they go so far that they end up worrying all the time. So I look at personalities and ask them, kind of like we do when somebody comes onto a DNA, how do you like to learn? Do you want to be told action 1, 2, 3? Or do you want more theory and you'll put it into action? What about you? Do you ask them how they like to learn, or do you ask them how much information they want, or how would you handle somebody when they come in and say, what do you think my chances are?
Yeah, no, of course. I love the idea of what you're getting at here in regards to what do we anticipate the person doing with this information, right? I think, your first comment there is not necessarily, here's a cancer screen. The first comment you made was, let's do their genes. Let's understand where there's weaknesses in kind of this way, this idea that cancer is not fed by one direct thing, right? Cancer is not exclusively caused by smoking. Does that contribute increased risk? Absolutely. But there's other elements. And I like that through this question of what are you going to do with this information? Does it increase worry? Does it increase stress? That needs to be part of the decision. How active do we go down this hole? Some people are comforted by more information, whereas others, to your point, get lost in it, and then it becomes something that can contribute.
Yeah, can speed up the cancer.
Absolutely. I don't think we'll ever see a study that specifically says this person worried themselves into cancer, but we categorically do know that mindset and stress and how you manage all of that, what are your thoughts rumbling around, that does contribute, right? And so I like that playing with it. I like that assessment, and I like assessing and really understanding with the person, if you had this information, what are you going to do with it? How is that going to impact your day to day? Because I think that's an important part. Is it something that's going to motivate you?
Yeah.
Or is it something that's going to have you lying in bed, biting your nails off?
So I just saw that Trudy just said, well, your genes are set, so I can handle either. But Judy, I'm going to challenge you. Your genes are there, but your genes, some are activated, some are not activated. And once a gene is activated, the rheostat can turn up like a hot water heater and we can turn it down. Now, we can't turn it off. However, the most important thing is if you've got one that's turned on and the water's gotten a little hot, your environment for inflammation's gotten a little hot, let's look at ways that we can turn it down. And if it hasn't gotten on, either because you've got a great lifestyle or you've got good genes or whatever, how do we keep it off? So prevention is key. I 100% agree, but sometimes it's modulation, and modulation is done with a lot of things. And Dr. Krista, you mentioned that cancers are on the rise. The major pharmaceutical companies are all gobbling up all the little cancer companies in the last couple of years. Why? Because of the increase in cancer. We have more toxic environments. We have poor food supplies. We have more stressed out people. There's more EMFs. EMFs bombard our cells and they get our cells all activated. And then the cells go, I must need to replicate because I got all this action. So we've got to look at our environment. But I think the other part of that is autoimmunity is going up. And where there's autoimmunity, there is a bombardment of inflammation, which leads from one to another to another. So I will tell you, in our family, I had the cervical cancer at 21 because of my inflammation in my body due to eating the wrong things and having the wrong environment around it. But my father's had 5 different cancers. So we have genes that produce, blooms of things. And so there are so much to be conscientious about when and where and how, and there's so many multitude of cancers. That's why I'm so excited that the DNA company is expanding their profile beyond just the DNA 360, which, a little bit later we'll drop some links in for those of you who haven't gotten the 360 yet. But we're going to truth bomb. Oh, there's B on top of it. Look, we have a magic DNA fairy who's dropping it right now. We have so many things we're expanding to because of the requests, because of the demands, and because of the quality of information you can get to decide your healthiest future.
Yeah. And so why don't we talk through that a little bit? So we have this woman before us and she's comfortable and she feels that this information is actually going to support her. She would action it. She wants to know, she wants to be proactive. What are those next steps? What are the options? So she's done her DNA 360. She's scrubbed through her life with you, right? She knows where she's weak. She's addressing those points. What's kind of the next steps that we can offer her?
Well, the neat thing is there is not just cutting edge, I'm going to call it bleeding edge,
Yeah.
research out there, which are multi-cancer diagnostic tests. And they're known, a biopsy is usually when you take a tissue sample and pull it out and then it looks under a microscope. This is known as a liquid biopsy. And we have a proprietary product, our DNA liquid biopsy, that will screen over 50 different kinds of cancers. Now,
Mhm.
there's a few companies out there that have them. Some do only breast, some do only, lungs, some do only gut. Ours goes across the board.
Yeah.
And many of them, in fact, I will say most of them don't do anything with brain cancers, but with all the cell phones and all the headsets and all the, I think brain cancer is a key one. And what it will do is it will look for DNA particles in your blood. So it's a simple blood test. And then it gives you a screening. Is there any evidence of genetic DNA toward a cervical cancer or a breast cancer or a brain cancer? And it allows to catch early, early, early. Now, I will do a caveat, which is all of us have cancer cells in our bodies at all times.
Mhm.
But our body, if it's healthy, manages it. Just like look at weeds in a garden. Okay, you're not going to have even a beautiful garden. You're not going to be completely weed free, but can you see it early and pluck it out?
Yeah.
And do the healthy plants get in and manage that so that the weeds don't take over?
I like I like that analogy. And I would also offer part of the power of scanning for many types of cancer, including brain, right? 70% of cancers in the US are not of diagnosed cancers in the US are not cancers that are commonly screened for. So brain is amongst them, right? We kind of, the conventional model is, well, we'll wait until we see symptoms, right? And so this nips that in the butt a little bit insofar as we're like, cool, we're not going to wait. We're going to wait till we start to see a little bit of that DNA evidence that something's happening up there. And then let's talk about what we do now that we know that that's there. Right.
And there's so few cancers that we actually screen for. I mean, women get breast cancer, they get a cervical cancer screen. Men might get a prostate screen.
Mhm.
Many of us, if you're fair like I am or like you are, we get, some skin cancer screen because we have a family history. We get colon cancer screen with a colonoscopy, but
Yeah.
nobody's scanning me for brain cancer or for kidney cancer or for lung cancer or
Yeah.
or
Absolutely.
for leukemia. And so when you can have notice with these liquid biopsies of, hey, there is a trend here, there
Mhm.
is X number of particles here, and based on your genetics, we
Yeah.
see that if there's going to be anything that comes, it's likely to be kidney, it's likely to be brain, it's likely to be. So not only does that go, okay, I'm going to do everything in my power not to get this,
Mhm.
but if I did, how am I going to manage it? And how much time do I have? Because to your point about early detection, I mean, the fabulous part about early detection is even in simpler things like breast cancer, it,
Mhm.
when you're in stage 1 or pre-cancers just with inflammation, it's 99% recoverable. Prostate, 99% recoverable. Melanoma, 99% recoverable. I mean, when it's localized, so my cervical cancer was called carcinoma in situ, which were full-on cancer cells, but they were localized to a very specific area, 99% recovery. Oh,
Mhm.
ovarian cancer can be up to 93%. Kidney and pelvis cancer, 93%. I mean, a
Yeah.
lot of these, when I had my first colonoscopy, and I've had multiple,
Mhm.
I had a polyp.
Mhm.
Well, the type of polyp I had was an adenocarcinoma. Takes 10 years to develop. I was 5 years in, and my GI doc said, you
Yeah.
were 40. You're not supposed to get your first colonoscopy until 50. Why did you get one now? And I said, because my dad had 17 inches of his colon resectioned, and I don't want to go there. And he goes, it's a really good thing. If you had waited till 50, you'd have the same thing that he did.
Yeah. Yeah.
Here, being proactive, it was snip, snip. I didn't feel anything. I was done.
Yeah. And I love that your awareness of your family history lent to two things. First of all, you driving an element of your care. There was no doctor that was like, cool, go do this. It was you petitioning, you advocating for yourself and seeking this out based on the family history. But then also to that end, the fact that that screen caught it before it was a thing. And how much more powerful would it be if we're scanning for several different, right? We know all these cancers are on the rise, largely, right? So if we're scanning for all of them, we're able to nip it in that infancy stage, which often, I find it very interesting now that because of these tools, because of these technologies, we're now seeing cancers in stages we typically never see them in, because we're catching them so early, right? When we talk about staging, there's nuance, but effectively the bigger the stage, the larger the mass, the more symptomology you're going to be seeing. And that's why we catch them in those stages, because it interfered with something enough that someone then was like, cool, I got to go to the hospital. So in the case of brain cancer, often it's a marked personality change. And at that point in time, there's something else that, like it's a very advanced, and the treatment goes from let's remove, let's prevent to let's react and let's address.
Well, I saw a patient yesterday, 76. He was a male, chronic cough. He's been treated for COPD. He's been treated for asthma. He's been treated for infection. Yesterday, they found out he has stage 4 lung cancer. And that's when they brought him and said, what can we do?
Yeah.
And at stage 4 lung cancer, that's tough, especially when you're in your late 70s. And the answer was, let's go for quality of life. It was no longer about remediating the cancer, because we should have found that ages ago. But there was lifestyle, there was the denial, there was fear of what if I find out? And now there's this massive rush in traditional Western medicine to, well, let's cut it out and let's start the chemo and let's start the radiation, to which he just put the kiboshes on it and said no. And that's why they brought him to me and said, what can we do for quality of life? How long, and so we decided on decisions that could support him the best we could, but also combining the best of East and West and putting it together so that whether he has 2 days, 2 weeks, 2 months, or 2 years, he can go life well lived. And you want people to have those choices.
Absolutely. And I think to the end of how far do you chase down cancer, be it as those preliminary kind of preventative diagnostics or in reaction to, or such a personalized decision, right?
It is.
Based on how much information you can manage, based on how much energy, effort you're willing to offer it, right? And I like that. I'll take a pause, and I value in your approach this comment of autonomy, right? I think there can be such velocity, especially around, oh, I have a history of cancer, it means you must be exceptionally vigilant, or oh, I have cancer and therefore you must do this. I think sometimes with the big C word, it becomes this elephant in the room where there's an expectation of this is how you manage it, and there's not this pause to determine how you in your health journey want to be managing it. I value that pause that you're putting in there, especially before cancer exists, in that how do we go about tracking it? And then separately in that moment, what do we do about it? And so I wonder, inspired by this last fellow, if we could shift into another example of how we could leverage different diagnostic tests in regards
Absolutely.
to. Yeah, so the other instance I would offer, let's say a fellow in his 60s, okay? And so at some point in his 50s, there was some flags, some PSA screenings that said there's concern of prostate that was monitored. And at some point in time, the doctor came back and said, okay, stage 1 prostate cancer, right? At that, I wonder if you can offer right off the bat kind of the conventional options that are on the table, right? Because we've shifted from sometimes very aggressive care to now a little bit more watchful waiting, observant waiting. Do you want to kind of offer to the audience what are those options for that fellow in his mid-60s who now has this stage 1 diagnosis?
So with the stage 1 diagnosis, you need to look at each cancer. Prostate cancer tends to be fairly slow growing.
Yeah.
So with diet, we make sure that we don't have hormones feeding the diet. I have become a major opponent of all the plastic water bottles. You notice that I have, metal that then is coated, or yeah, there you go.
Cheers.
Because the softer, squishier your plastic is, the more plasticizers, the more hormone disruption, the more you're going to wreck your endocrine system. The second thing is that, again, with a prostate, there are a lot of conditions and research that's now showing possible parasites, possible fungus. So how about we look at diet and lifestyle changes to remove fungus? Do you have a moldy house? What kind of foods do you eat? What can we do to lift that? Perhaps some detoxifications. And we look at how frequently do we do diagnostic tests? Are they ready to have a biopsy? Maybe they had a biopsy and that's where they saw, but in a prostate that can be the size of a walnut, then if you have, say, even 3 or 4 pinpricks, that's what you get. You get 3 or 4 pinpricks, depending on where in the prostate. You may have one small area, you may have it throughout, but if it's stage 1, it's likely in one small area. We look and learn. We also have a test called PGX, pharmaceutical genetics. Now, with a PGX test, it's going to give you a list of, with your genetic type, what meds do you respond the best to? Because let's face it, a lot of medicine is hit or miss. Does it work? Does it not work? Do I have side effects? Which we know side effects are really direct effects. They're just not the direct effect that it was marketed for. Okay. So how about if we could take some of that guessing out? And if you have to get into whether it is a hormone reducer, so that we're not feeding if it's a hormone-based type cancer, or if we need to do some type of a chemotherapy, what chemotherapies work the best, what hormone blockers work the best, how's the best way to support your system in an anti-inflammatory way, because oftentimes the body can reverse. There's several times when people have cancers, they shift their diet, they shift their mental state, they shift their lifestyle, and then boom, it goes away. And so it's because we gave that garden, again, going back to the garden example, we gave the garden the nourishment it needed to thrive and feed the good stuff and not the weeds.
Yeah, no, I love that. And I think it speaks to this idea that, every day cancer comes up and the body has capacity to quash it. Right. And so when we know that there's a little bit of a bigger uprising that hasn't been immediately quashed, the body has the machinery and the tools in order to support that for many forms of cancer. And so enabling and empowering those tools is often one of the better methods. And so I wonder if you can speak a little bit to, because I often see when someone comes in with this big C word, right? There's 2 sorts of responses, and I find this is to an extent predicted by some cognitive or mood behavior genes, right? There's one sort of response where they become obsessed with their cancer and their entire life moving forward, even if it's a stage 1, even if it's something to an extent that can be resolved and be put into inactive disease, that becomes their life. They no longer have a life, they have a cancer. And then the other flip of that, right, is the complete avoidance of like, oh, I have this thing in me and I'm never, I wonder if we can talk a little bit about those very natural reactions. I don't want to sit here in judgment of either of those, because I can't imagine getting that big C word And I think it's very natural to kind of have a fight or flight reaction in the sense I'm going to run away, I'm going to freeze, or this is going to become my life, right? I wonder if we can pause there a little bit, because I think as much as we want to talk about here's the diet, here's this, here's that, we also have to talk about the fact that you're living concurrent with this cancer. And so how do we do that in a way that your life is not cancer?
Well, I can tell you personally, there was a great deal of shame being 21 and all of a sudden having cancer. So, you go in, you expect everything to be okay. You expect everybody to go, yeah, you're just fine. You just have a yeast infection. And then all of a sudden it's like, no, your pap came back bad. You've got carcinoma in situ. You're living with cancer. And we got to address this. That whole, okay, so with my DNA 360, my neurotransmitters, I get shocked. I do a little bit of a panic freeze, and then I recover. Now, the beautiful part of that is I get an adrenaline rush. So I would have been a great ER doctor, because I run with the adrenaline. I'm great through the crisis, and then I crash afterward.
We all know that. We all know the profile. Yeah.
Yeah. And that's what I did, was the adrenaline rushed. I got to fix this. And I will tell you, I was so naive back then, even though I was full in pharmacy school and immersed in Western medicine.
Yeah.
It was, well, of course, I'm going to get through this. But it was really more the cost. At 21, they wanted me to go through 1 or 2 bone marrow transplants. It would have been $1 million worth of medical debt at 21. I knew I would never dig out of that. I was just so Scotch-Irish determined not to take that debt on, that there has to be another way. And so I think when a patient can go, all right, here's my problem. I'm obviously not the first, there's a solution. And then when they have a practitioner that they can hold hands with and talk to somebody about that whole emotional, whether it's a family member, or whether it is a counselor, or whether it is a genomic practitioner, somebody who can go, okay, let's help you in this moment of and gently guide you through. And I always love your sensitivity. I don't think I'm nearly as sensitive as I should be, because I'm just let's just fix this shit,
Both approaches work, because I would offer
they do.
There's a large population that just needs marching orders, whereas another population that's soft, squishy, and fuzzy and needs a hug before we can get any marching orders.
Yeah.
And being able to show up wherever that person is, be matched with the appropriate practitioner.
Exactly.
That's important. And so I would really encourage, for this example of this man who has been given the stage 1 diagnosis, one of the first things I would suggest to him, not knowing him because he doesn't exist, but not knowing him, would be understand who's going to be part of your care team and make sure they align both with your values, how you want to approach it, how aggressive, how not aggressive, what is your mentality when it comes to it? Do we want to go Western? Do we want to go alternative? Do we want to go somewhere in between? Make sure that person, that care team, and I would imagine with any cancer, it's going to be a team. It likely will not be an individual. Recruiting those people for you is so very important. Do you want someone as mushy and bushy as me, or do we want someone who can give you marching orders like Dr. Steph, right? Those considerations are super important, because to your point, if there's going to be this experience of shame and this experience of shock and this experience of debility for a little bit, how do we support that so that you're not stuck there and not ignoring something when you would prefer not to be ignoring it?
Yeah. I'm wondering, with our questions that came up, what is our audience looking for? Are they looking for how do I do prevention, or are they looking for let's dig in and get it done?
Yeah. So I'm seeing a lot of people here for themselves to be that, awareness of their own healthcare journey, which is so great. I love that. And then I would imagine some of that motivation here is that cancer runs in their families. And so there's this element of, what do I do knowing that, right? What do you do? What else are we seeing? What else do you see? That's
Oh, I
amazing.
see also, I love that. Yes, I'm here for myself. So 60, almost 70%. Yeah, because I don't want to deal with this paradigm. Does it run in my family? Yep. So because I know it runs, I'm here for prevention. That's awesome. You know, with women, have they done breast cancer screening? I know there were a couple questions earlier. So with breast cancer screenings, it's interesting to me because there's the thermography, which has no radiation. There's traditional mammography, which in some cases catches things so early that catches things that maybe didn't need to be treated. I've actually read several studies that are actually anti-mammography on an annual basis because there's like a lot of stuff that they're catching that would never have developed into anything. I happen to like the 3D mammography, where you can really get in deep and really get in and be able to, you know, almost have this clear picture. But I love the liquid biopsy for that. There are some DNA companies that tell you they check for specific genes that are breast cancer related. But what they don't tell you is that they're for only a small segment of the population, like an Ashkenazi Jew population, which I happen to have none of. So their test, when they tell me you don't carry this gene and you're not going to be impacted, is completely inaccurate for my genetic makeup. And I feel like that's a disservice with something like a liquid biopsy. This is specifically for you. Is there stuff there? And is it targeted for you? And I love that N of 1, and anyone who's in science knows N of 1 means it's you, you, and you, and it's all about you. Whether it's breast cancer, whether it's a PSA, whether it's something else, this is unique to you and only you.
And I would offer along that vein in regards to being very selective and specific around what sort of screening tools you use. Ensure with whatever company you go with, and this applies to us, and I have confidence in our test, but I still want to share this because I think it's important. There's a lot of companies that claim cancer tests, and yet when you ask practicing oncologists, would they ever adapt this into their practice because it's been scientifically validated? They say no. So for example, we look at DNA, we have direct evidence of, did a tumor cell shed DNA evidence that it's happening in the body? Whereas other companies will use, and I won't go too technical, they'll use something called methylation patterns, right? They'll say, you know, is there evidence atop DNA that cancer is happening, right? That you have genes that enable cancer, not that if it's happening, genes that enable it, and are they active, right? That is not used in clinical settings to validate, is there something happening? Okay. And so be very careful. I just be very specific, ensure they're measuring actual cancer, ensure they're being general enough so that they're catching it all, versus, to Dr. Steph's point, a very specific population that unless you fit directly into there, it's not of much help or use to you. Yeah. Yeah.
And I love that the word is getting out to more and more practices, whether it's MDs, DOs, nurse practitioners, in my case, pharmacists, nutritionists. And yes, there are a lot of people that are getting information through the DNA company. I see we've got a question, you know, are you training health professionals how to do this? And we do. We have our DNA U, where you can incorporate this into your practice. And we can work with you on that, or you can incorporate your practice. That way, you're able to bring a lot of this information with confidence to your patient population, because sharing this and offering this is so valuable, so that you can provide quality care and a depth of quick care that isn't seen in a 7-minute or 15-minute visit.
Yeah. So if I can just speak quickly to that training, or at least that experience, because I think it's important to understand that. So as a patient, right, if you were to purchase this, what would happen is we would arrange for a blood sample to be taken. And then that blood sample, quite literally every ounce of DNA is analyzed within that. And that is compared to a cancer library. So we can come up with, what is that response? With those test results, that is then reviewed with an oncologist. Okay, so we don't just toss those test results back at you and say, good luck interpreting them, right? There's an oncologist that's going to walk you through, this is what the test means, especially in the context of your current health, right? And then separate to that, here are next steps. So if there is a marked concern, right, there's a flag of, hey, you know, maybe there's a bit of breast cancer budding, they can support with next steps as to here's what imaging you might want to consider. Here's an oncologist you might want to connect with as to next steps. You're not abandoned in that. For the healthcare providers out there who want to incorporate this into their practice, thank you. How we support you there is education exactly on what this test is, how it's screening. I see a beautiful Kathleen. I adore this question around sensitivity and specificity, right? We'll dig a little bit more into the dirt of the science behind the test, the lab values, how sensitive, how specific it is, high in both regards, especially the sensitivity. I don't have an exact number, but we're sitting in the high 90s there. And so we'll walk you through that and then also support your patient journey, right? So that you can offer these tests and then engage and be part of that consult with the oncologist and your client, however they choose to have that journey. So I love that question, and I really hope you do follow up and engage with us at DNAU so we can further support your practice. The goal of what we do at DNA Company is, to Steph's words, bleeding edge, but making that accessible to people. So we're not just tossing science out at you and being like, good luck. We're walking you, we're humanizing that science, and then most importantly, giving you the so what, right? A test with a positive screen is useless if you don't have a so what do I do now?
Well, and I like what you said about, okay, so let's say we have this gentleman, 60s, he's got the prostate, maybe he does a liquid biopsy and nothing else comes up, or maybe a couple other things come up. So he's got prostate, maybe he's got some kidney stuff. Again, it's not just, hey, you got some numbers, so what do you do with it? There is, here's your follow-ups, here are potential next steps, here's the diagnostics and how frequently you want to do them. Here's what a positive step on those next diagnostics would look like. Here's some things that would say, this is progressing, let's get a little more aggressive early. So it's getting the lay of that land, getting that baseline, and then you continue to follow up based on what your results are. And the beautiful part of that is now you've got a team, and I think we should really talk about our team at DNA and some of the new team things that we're going to do, because everybody here has a little bit, different. Dr. Krista has a whole tech and AI background. And on top of that, she's a naturopath. So she's this nerdy techie act, and then she's got this sensitive, sweet, naturopath, and you put it together. And she digs into research. I'm a former pharmaceutical medical researcher, but man, she blows me out of the water with her technology. I'm like, man, I feel like a newbie here. I have really dug in for so many years of clinical service and having the whole Western medicine drug piece, and then have the alternative nutrition piece, and you put together, mine is really food is your medicine, and food and lifestyle and prevention, and how do we get you off the pharmaceuticals? Because if you look at most pharmaceuticals, except for like short-term antibiotics, pharma wants you on them for years and years and years and years. They're not looking. In fact, cancer, name one cancer that they have cured. No, cancer is a machine. They want you on the cancer again and again and again. They want the recurring, they want all the follow-ups, because cancer is a machine. And it is abominable to me, with all the medical information we have out there, that we can't say, this is gone, this is over. Well, it's not. So the whole idea, yes, we discussed is prevention, but then we also discussed, how do we keep that from being your reality? And how do we keep you in the healthiest form you can? It doesn't mean you can't recover from it. Obviously, I've recovered from 2 of them and going strong. I used to want longevity. Now I want quality, but it took a team, and it always takes a team. So maybe you can do an introduction, and I see that we've got Tracy released her cameras here. Maybe we can bring Tracy on to talk about one of our new offerings.
Why do you always come to me when I'm sitting
here?
I'm all sitting here having a break, listening to YouTube. Go on.
Yeah.
Hi. How are you?
For those of you who don't know, Tracy Wood is our illustrious CEO, and she is a major driving force behind where DNA Company is going. She puts together some of the most incredible partnerships around the community, and we had so many people asking for more. She came up with precision medical care, which is a very highly personalized offering. And Trace, will you tell us a little bit more about that and where we're going with that? Liquid
Sure.
biopsy and precision care and
Absolutely.
what people are asking for.
Yeah, so I'm a legend in my own mind. Yeah, we
She'll tell you too.
totally, I will. I totally will. You know, we started to, when I first started here, I got a lot of different emails from people, right? Asking questions about the 360, asking what next? What do I do next? And then some of those conversations led to a bigger conversation around, well, you know, I had my DNA done in, you know, 2022, and, you know, now I've got a cancer diagnosis. So we started looking at a lot of research, and in fact, I think it was Med News Today, I think it was, back in January of this year, released an article, and the article said that basically there's this new blood test, and we're not the only ones that have this. It's important to know that. But there's this new blood test, and it is detecting 93% of stage 1 cancers in men and 84% of stage 1 cancers in women. Now, how many of you have ever had a family member that said to you, I have breast cancer and it's only stage 1? It doesn't happen. Why does it not happen? I mean, Dr. Nielsen, you know the answer to this. Because we're not finding it at that point. We're not finding it because maybe it's not formed to the mass that becomes detectable. We're not symptomatic. There's no symptomology around it. You're not doing a self-exam and finding it because you can't yet. Right. So when you do find it, generally we're at stage 2, we're at stage 3, or God forbid worse, right? So they've been messing with these blood tests, and I mean, really, there's, I think it's BMJ Oncology Journal has some stuff on this. I know people are asking for some research on it, so please do look those things up. So we went and we found a great partner that operates out of the Mayo Clinic, and we said, listen, we want to offer this test, but we want it with the genetic insights, right? Mm-hmm. So the genetic insights are important to us. Our DNA genetic insights are different. Why? Because we're not looking to tell you if you came from Poland, because we don't care. We're not looking to tell you how many family members you may have around the world that you don't know. And, you know, maybe dad got around a little bit. We don't care. None of that matters to us. It's late in the day. Give me a break.
I'm enjoying it. You keep going.
As long as I don't swear. And everybody on here, please be advised, I do swear. It just comes out. I apologize in advance. So we started doing more research with people to partner with, right? And we wanted to make sure that our genetic insights would be factored in how this test and the results were completed. We found a great partner, and liquid biopsy was born. So our liquid B product is not unique to us. The name is unique to us. But there's a lot of people doing it. We are hopeful that at some point more people will get CMS, or the Department of Health and Human Services and Medicare, kind of off their backside to approve these things. It would be so much easier to treat a stage 1 problem as opposed to a stage 3 problem. But we all know that medicine is big business. We all know that chemotherapy, I mean, chemotherapy drugs, biologics are $20,000, $30,000 a month. Okay, nobody can do that really, right? I mean, that's not something people can afford, but the insurance companies will bill them at 150% to Medicare rate. Medicare rate's going to be what, 20% of that, Dr. Nielsen?
Generally.
Right? So they'll pay them to 150% of that number. So between $4,500 per round and $6,000 per round. It's a racket. We all know it's a racket, and everybody hates it. So that's why we started to look into precision medicine. Precision medicine is designed to really meet the patient where they are. Everybody says it, most of it's bullshit, but the fact is, is we literally interview people for these programs. We don't take just anybody into them. We have a panel of 3 people with different areas of expertise that sit and conduct an interview with the potential patient. We have them fill out a medical intake, any lab results they've had within the last 12 months. We review all of that prior to meeting with them. We go through and we find out what their objectives are. Some people are at the end of their rope. Some people are in the middle, and they're so confused by all of the crap that comes flying out in different studies that does nothing but contraindicate one another. So anyone can be a candidate. It's important to know I am going to cap a certain number of new patients into the system a year. Why am I going to do that? It's not because I don't want to help everybody. I want to help everybody. But I can't do that and effectively do that if my doctors are stretched so far. Then we become the treat and street people, and that's not who we're going to be.
Yeah.
So it's important to understand that the precision program is by invitation only. If somebody wants to be considered, all they have to do is send me an email to my CEO email. It's ceo@thednacompany.com. Beth, if you can drop it in there for me, that'd be great. And let me know what you're looking for. Let me know what's happening to you. I want to understand where you're at. If you are not a fit, I am going to tell you. I have to tell you, out of the 20 interviews I've done in the last 2 weeks with 2 of my practitioner team, we've only taken like 30%. Because a lot of these people did not need this. They did not need this level. They did not need this depth, but some did. And those that did, we designed the program for them. So there's a multitude of testing involved in this. Liquid biopsy is one of them. Epigenetics, including a follow-up for barometer of progress. PGX, DNA 360 is a minimum you have to have before you come into this. If you haven't had that done, you will not be considered a candidate. Everything starts with your genetics, and we have to know where that baseline is. So I know I had one person say, I really want to do this, but I don't want to do your DNA test. And I said, well, nothing but love for you. I gotta go.
But you know what, I want to address that
Right?
for a minute, because
Yeah.
there's a lot of DNA companies out there, but a lot of them have fun to know facts, kind of like you were talking about how many people have this DNA and are your second cousin.
Can you fold your tongue in half? Yeah.
What does cilantro taste like?
Exactly. But we have 73 actionable DNA SNPs that you say, I'm having this symptom, I have this SNP, and then this is what we can do to tweak it up or tweak it down. As we were talking really early in, if it's activated, we can rack the dial on it. Now, the other thing is we continue to do research, and, Dr. Krista, Dr. Lara are amazing, with that, Dr. Mohammed, Bryce. And I know that we're in a couple months adding some more SNPs. And if you have the DNA test now, you get the updated results. We're not going to say, oh, the updated results are another $99. No, you get that. And I know we'll continue in next year. We're not doing that? Oh.
Of
No,
course I
just
approved
get
that.
it. We decided that.
I did. That's true. I did.
Yes, you did.
I did.
So I love it that it's actionable. Again, we keep talking about action to action.
Right.
What are the things you can do? How can you follow up? What results are you looking for? How can we say yes, no, and turn that dial? Because what's the point of having all these tests if you can't move the needle?
Right. And the thing is,
further
sorry,
that a little
please,
bit.
go ahead.
No, because I think often a question we get is, I've done 23andMe. Can you just take my results and use them? Right. And the answer is twofold. First of all, kind of. 23andMe, once they shifted a few years ago, and they've actually taken out a lot of genes. They don't give us access to everything that we want. So it was before a certain date, maybe, definitely not after another date. Okay. But separate to that, 23andMe tends to focus on SNPs, single nucleotide polymorphisms. Okay. And that's what the example is, kind of opening up a book and looking at a page and saying, is it this letter or that letter? Okay, it's very specific, it's in the ground. A lot of that will determine certain disease risks, certain traits, etc. So they just look at letters on the page. But we know when you're looking at a book, there's a lot more within that book. How long are the chapters? What are the chapters about? It's different levels of information. And that is something that we specialize and focus on. that you're not going to see elsewhere. It's really, I love it. I get to do bougie science, right? So instead of just looking at letters on the page, I also ask about the qualities of the pages. How much information is there? The more information you have often can be beneficial, but sometimes is not. So we really don't look at just the letters. We look at how those words are written, because that's very important. Anyone can read a sentence, but you have those staged directions, and that's part of what you get when you look at the information and go a step beyond the SNPs, or these single polymorphic nucleotides. Okay.
I let her say all of the big words because I just can't do that.
I mix them up. You can tell it's the end of my day because I just mixed up SNP. It's okay. We were so close. I got it the first time, so in the recording.
You did get it the first time, and I wasn't going to point it out.
Nobody else would have
Okay, I
noticed.
clocked it. It's okay. I clocked it.
So ladies, doctors, I apologize. I do hope I answered your question. Our precision program, there's nothing like it. It's going to be about a year. It's a lot of follow-up. It's a lot of connected tissue. It's a lot of testing, but it's a lot of action, and it's a lot of progress and checking those markers on sometimes 2-3 times a week, depending on what your rate of tolerance is. How often do you want to have that connection between your practitioner? For me, it's once every 9 years and I'm good. But some people want to talk to a doctor every 2 days, every 3 days. They want to feel like somebody's listening to them. It's an experience unlike anything else you've ever done. If you've ever gone into, there's some concierge clinics up in Miami, New York, and Beverly Hills. Shocker. These are $50,000. And people are only there for a week, 2 weeks, maybe a month, if that. And then they're on their own. So if you can't take in that massive amount of information about you, your body, your health, and then make a plan out of it, and then hit the bricks in 28 days, nothing but love for you, but you're done. So that's why this is so different. We want to travel this path with you. We want to help you down whatever road it is you need to go. Some of you will not be a candidate. It's not a personal affront. It's just not a fit. If we have something else that is a fit, we will make those recommendations. But this is, there's a question from Merlene. I hope I said
Is
your
the precision program open to practitioners? Absolutely.
We ought to treat a doctor, come on.
Yes. Absolutely, because they take what they learn and they treat their patients.
Of course.
Teacher. Absolutely. I also
Absolutely.
love that Dr. Steph just jumped in and made an executive decision. Just Tracy that said yes. It was Steph that was like, yep.
They boss me around. You guys have no idea. I've been here since Monday. I haven't left my desk. So yeah, send me an email and I'm happy to have that conversation with you. From the Q&A, Tracy, is it worth applying for precision medicine if you don't have chronic illness yet? I have low-level inflammation and siblings with multiple medical problems, including cancer and autoimmune disease. Wondering if I'm a ticking time bomb or dodged a genetic bullet. Well, make sure that both of you have all the same parents on both sides. Not that I'm saying anything about your folks, but
She went there. It's late. That's fine.
I totally did. You said I could. You said I could. Okay, so who asked that question, Beth? Unmute them. Let me talk to them. We're going to do this
That
live.
was from Diane. Let me
get.
just find her here. Hold on one.
Marissa from Australia loves you. And you know what? Because you're like, she's actually Scottish, Marissa. And
I am a Scot.
like Australian.
Right there behind my
Very
desk.
correct.
There's the St. Andrew's cross right there.
Yeah.
I bow to it every morning when I come in the door.
That's
So-
from Diane Sondheimer. You should be able to speak now, Diane.
Hi,
I'm
Diane.
here. Can you hear me? Hello.
Ma'am, how are you?
I'm good. You?
Good. I'm well, thank you. It's nice to meet you.
You too. So both parents are the same. LOL. Yeah. As far as I know,
That's awesome.
all siblings have the same parents. As far as I know.
As far as you know, that's awesome. So, Diane, the siblings that have chronic conditions, younger or older?
One is 4 years younger. The other is almost a decade older.
Oh, see, that one's already screwed from the gate right there. I mean, I'm just kidding. I'm just kidding. So what's the chronic condition? Do you mind sharing?
That they have?
Yeah.
A sister with rheumatoid arthritis and metastatic melanoma to the liver. Nice. And then my brother has diabetes and melanoma of the scalp, which they got before it metastasized. And so they must have, I think, and then my brother also had terrible depression for months. So, but I have had nothing
Dr. Nielsen, what are your thoughts?
except for low-level inflammation, which I cannot figure out what's causing it.
Well, and so that was the
Autoimmune
other thing I
diseases.
was gonna say. I was gonna say gut biome. I was gonna say DNA metabolism. Diane, have you done our 360 yet?
Yeah.
Okay,
How long
so,
ago?
okay, I'd go back
Um,
and look at your DNA for your vitamin D processing. I'd look at your gut processing. With the autoimmunity, that obviously inflammation sets you up for, you know, the different cancers. Then you've got the melanomas. I would wonder how your lifestyle is different than theirs as far as foods you eat or products that you use in your home.
I
you
think there's a big difference.
Yeah, do you live in different parts of the world, just out of curiosity?
No, my sister lives down the street. My brother is in Chicago, but I will tell you that my sister had 6 Diet Cokes a day for 30 years.
That explains a lot.
Stuff like that, and I would never touch that stuff.
Yeah, and I heard her say, as we were kind of doing, is she said total lifestyle difference.
Yeah.
And so you have lent toward the healthier lifestyle, but and again, you could be interviewed for precision, but it sounds like you've done a lot of the right things. I would probably say that we have other programs that would benefit you. I don't think you need a precision program because you're not experiencing those. I would say you're more of a, let's get you in, review, maybe tweak a few things. Maybe you have 1 or 2 things that you do want to work on, but I think that you would probably not be what we're looking at for a precision candidate. But being proactive, you know, especially with all that history of cancer, I would say a liquid biopsy would be awesome for you so that you could say, in my DNA, what is my weakness, so that again, you can head it off at the pass and not have to go down that route.
And
So
Diane,
does that mean some coaching? Is that what you're talking about? Some
Exactly.
individual coaching?
Yeah.
Yeah.
no, I wouldn't say just coaching, Dr. Nielsen. I think Dr. Kosterman and I probably are going to agree here. I think that what you could do, Diane, is you could go into the longevity program. And in that you've already done your DNA 360, so we can do your PGX and check your pharmaco. Definitely check the gut, like Dr. Nielsen said. The epigenetics to see at what rate your tissue is aging, and to see what age it is now. But I think a further deep dive with a practitioner, one of the doctors, to go through your genes and then kind of match up what it is that you do differently, and to continue to drive that behavior, but also to go through some supplementation. So I think you are a candidate for a program, but I think the precision program may be more than what you need. So maybe here's what I would do. Diane, send me an email, send it to the CEO at DNAcompany.com. And I'll ask you a couple of questions and kick the ball back and forth. And then let's see if it's something that would be a good fit for you. And if it is, great, we'll put you on the interview panel. If it's not, at least I can point you in the right direction to support you.
Well, I'm glad you're going to kick the ball and not her. I thought you said you were going to kick her around.
Thank you. Thank you all.
Thank you, Diane. Have a great night. Thanks.
Yeah,
So
you too.
guys, I'm gonna get out of your meeting because my CGM is going off, which means it's time for apple juice. So I'm gonna go. If you guys need me, you know where I'm at. Any of you that want
Just
to email
before
me,
you disappear, Tracy.
yes.
I wonder. Oh, I know, keeping you late
Thanks
in
for
class.
hanging around late to hang out with us.
You know, you two are my favorite, but don't tell the other kids that.
It's officially recorded. This is documented in history now, and I'm gonna post it everywhere. quick question. This is coming from both Chanel and Jennifer. So fellow Canucks, hi Canadians, welcome. They're asking what their options are in regards to liquid biopsy. So I wonder if you can just offer who is eligible for liquid biopsy, and if you're not eligible for it, possible solutions thereof.
Okay, so right now, liquid biopsy is only available in the United States and the United Kingdom. With that said, if you are in Canada and you want to have a liquid biopsy done, we can coordinate a venipuncture to a facility in any of the border towns. I know we've got actually a couple of people that have crossed the border into New York, stayed at a hotel. We've sent out the nurse and the phlebotomist. They've done the blood draw, and then the test gets run. Health Canada does not want this type of information available in its country yet, which is unfortunate. And same thing with Australia and New Zealand, by the way, because the UK actually applied for it to be acceptable in both of those jurisdictions, and Australian government and New Zealand said, no, you can keep your fancy cancer testing. We'd rather treat it than cure it. So hopefully that answers the question.
It does. Dr. Steph, do we dismiss her? Is she allowed to go now?
Am I allowed to go home now, girls?
She's allowed to go.
Okay. All right. Thank
See
you
you
all
tomorrow.
very much. Bye, girls. Thank you.
Love you. Bye-bye.
Love you. Bye.
So there was a quick question from Linda. You know, I don't take any pharmaceuticals. Do I need a PGX? I would say
Question.
no. So, but what I would say is PGX will say for antidepressants or for statins or for chemotherapy, it'll tell you the ones who do best. If you're not taking them and don't see that in your future, I would not say you would need that now. But I would look at an age rate test. And the reason I'd look at age rate is we look at the inflammatory markers, and we look at your metabolic processing, and we look at the things that your body are doing. How well are you doing it? So in my case, I'm almost 61. You know, when I was 30, I did something that's like an age rate test, and it said I was aging at the rate of 80. They sent me another test because they said, you can't be. We had to do something wrong with the test. Well, they didn't. I had so much inflammation post my cancer at 21 that at 30, I was still aging too fast. Fast forward, when I was in my early 50s, I was aging the rate of a 30-year-old. So you can reverse that, and time can stand still. So if you're not on pharmaceuticals, I'd rather see you get a gut test, because 80% of your immune system is in your gut. So the gut 360, or I'd like to see you get an age test so that we can look at those metabolic markers and know healthy aging and healthy longevity is all about how are you processing, what are you doing with it?
I'm laughing right now because I'm going to offer a differing opinion, and I think this is
Okay.
the value of having several practitioners on your care team, because you get to hear it all. And I'm doing it with Steph because I know she can handle it. I would offer, if budget is not an option, I think if budget is a confinement or a consideration, Dr. Steph's answer is 100% perfect. But I also sit in the space, given my computer science background, information reigns supreme. And the more information I have access to, the happier I am as a little nerd. And so I would say, in regards to that pharmaceutical test, right? Not trying to upsell, not trying to sell anything you don't need. I more think of it to the end of prevention, right? In particular, you get that test, it goes to your doctor, and heaven forbid you ever need a prescription, right? We all get scratched. There's always that risk of infection. Knowing what agents are best based on drug gene interactions can be really, really important as to guiding that prescription. And again, you know, you have to balance budget. There's many considerations. But again, I side on the side of more information is often better. And I, as a doctor, like having more information. And so as the naturopath, instead of the pharmacist, I'm enjoying the poetry of this. I would suggest getting it.
So the pharmacist says, eh. The naturopath says, sure, why not? Fair enough. I can live with that.
And that's why you have a healthcare team, right? You hear both opinions and then you get to make your decision. I think this is where the autonomy, this is where a healthcare team comes in, because a huge part, I think, of the future of medicine, this is what you see in DNA precision and just cancer care, I would offer in general. What needs to found it is humility, right? Given the volume of research and given the volume of information that is coming out, it is impossible for one person to know it all. And so it's really, really, really important to not only have several eyes on it, but several perspectives, because I maybe have heard of a treatment that Dr. Steph has not heard of, and vice versa. She's heard of so many things I've never heard of in both the conventional and natural space, right? It's really important that you get several heads on that, and they're coordinated heads. They're heads that are talking. I think when I spent time supporting adjunctive cancer care, a lot of it was palliative. The most difficult time I had was when a patient would come and say, I'm going to talk to you, but I'm not telling my doctor about it, as if they were two separate bodies because they were two separate doctors. That cohesion, the coherence is exceptionally important. However natural, however pharmaceutical, what you're doing is, it's still within the same body. It's still the food going into the same body. It's still the same stress. There has to be oversight of that body, not just because you have different doctors, it's different bodies.
Mhm. So I see that we've got a couple really good questions. One from Linda. She says budget is a huge issue, but she's got a husband with stage 4 prostate cancer. So he doesn't need a liquid biopsy. You've got, something that you're actively dealing with. But I would say a PGX in that case, so that as they're targeting therapy, whether it's hormone therapy or blocking hormones or chemo, you're going to laser target so that they don't spend time wasting. That is one that I would totally do with someone like that, so that you can give those practitioners that you're dealing with the most efficient therapy. Now, it's also interesting. Some doctors have been educated enough that they go, wow, this DNA stuff, it's really cool. What insight? Some of them are so clueless, they say that has no clinical relevance. Now, that's what I'd like you to address. When I hear a traditional practitioner say, or providers say, that has no clinical relevance on anything that I'm going to do, I'm like, are you stuck back in the 40s? Because it's like, we've come so far, and especially our company that actually has actionable, like you said, it's not just the letters and the traits. This is results driven, totally results driven.
Yeah. And I think with the rate of innovation when it comes to medicine, I think one of the best providers that you can ever find yourself into, especially if you're introduced to something that you've never heard of, the best answer you could hear is, I don't know, but I'm going to look into it to see if it's valid. I think that's a very valid response there, right? And so, when you encounter, per se, a clinician who has decided they're not open to investigating a new tool and the research and the science behind it, right? To me, that's a little bit of a warning signal, right? As to they're not even necessarily keeping up, or they're just not willing to collaborate, right? No doctor is going to know it all. And so I think in my mind, that's kind of an opportunity to seek other opinion, to seek additional support, and to expand the team there. Because I would offer with liquid biopsy, there's a lot of clinical validation, and medicine is slow to adopt for good and bad reasons, right? We want to be very careful with the care we're offering. We want to be mindful of the care we're offering, but it's very slow to adopt. And so there's almost this conventional opinion of, unless I learned it in med school 40 years ago, it doesn't count. And we know a lot has happened over the course of 40 years. So that's kind of where the autonomy comes in. That's where the self-directed medical care comes in. Yeah. Does that make sense?
It does, totally.
Yeah, and it makes me sad. Here comes the squishy. It makes me very sad that when you're presented with either I'm worried about big C word or I have the big C word, there is an ask that the patient guide that journey. That makes me a little bit sad. I wish we had a medical system that guided that so you didn't have to, right? So you didn't have to become your own expert per se. But that's where we are, right? And so I think aligning an intelligent healthcare team with very intelligent data and good screens is foundational to that journey.
Well, I'm squishy on that with you as well, because at 21, I didn't have a group of people that said, here are all your options. It was, let's chop your cervix off. Let's burn it out. Let's put you girl in the plastic bubble and, wipe your immune system out. And computers were so new back then. They said it was kind of like a Control-Alt-Delete. we just hope it'll regrow okay. Well, nobody knew I was a celiac and also dairy sensitive. And so what they wanted to do was put me girl in the plastic bubble. And what would they have fed me in a hospital? What does hospital food look like? It would have been grilled cheese sandwiches. It would have been cakes and popsicles.
If
It
you're
would
lucky.
have, it would have been cereal for breakfast or oatmeal. I'm allergic to all of those. So I had to have no immune system. And then it wouldn't have allowed my immune system to rebuild at all. I would have died. So died with $1 million of medical debt and passed that on to my folks. I mean, oh my gosh. I think that's the beautiful thing of how far we've come in medicine, and that we have so many different types of practitioners now, and they can jump into all of the different aspects, or they can have their aspect and then they can partner with somebody who has a different aspect. And just like our differences on whether the PGX was appropriate or not, it's okay, because then the patient has information, they have support and they have guidance, but then they get to make the final decision.
I see that as our role, Dr. Steph, right? In the sense of, I'm aware of this space, here's my opinion on it, and here's other options. Because you don't have to follow necessarily my opinion, right? When we talk to that person who's trying to decide, am I an ostrich and not going to ignore everything, or am I going to get too data driven, or am I going to be somewhere in between? It's about discussing the options and what those options, what that path looks like, and then supporting that path.
Yeah. And we've got a couple people, in fact, Yvonne said she's got to take off, but she's a functional medicine coach that specializes in oncology. So I love that. And I love that somebody like that is going to put this in her toolbox. And yes, everyone will get a replay, so you can go back over. I also saw some questions about pricing. There's all sorts of packages, if you will email Allison, and we can put Allison's up, or email Tracy. They'll go through packages and pricing. I mean, one of the beautiful things about being a clinical practitioner is we don't have to deal with that. Business end deals with that. And some of the things run a couple $100, some go up more than that. It just depends on what all you put together. Some of it's reimbursable by insurance, some insurances, some is not, so. But a lot of it is done with your HSA or your FSA or your YSA, so that it is healthcare that is reimbursable. So that's something else you can do.
And I think I'm just looking at a question. I won't call out names for this. There's someone that's speaking to, they're currently in a program, and they have a history of a skin cancer. And the question is it appropriate? I would say definitely discuss it with your practitioner. I don't know the history there, but I would offer, if there's a history of cancer, screening for recurrence is a very important part of the forward-looking care. And part of what the practitioner can guide you on is the frequency, right? Every cancer diagnosis, we have some insight into how aggressively it can become active again, right? We don't say recur, we say become active again, right? And so I think they can guide as to the frequency with which you do the reevaluation, because again, you always have to be monitoring that garden. And you want to be part of that process of identifying a weed when it's small and supporting the body in the management of that weed while it's still small.
If we go into our Q&A, because we're getting close to the end here, I love this question, and you're so good with the science. I'd love for you to answer it. Can you explain how the estrogen toxicity increases risk factors for cancer?
Yeah. So within our test, and this is the DNA 360 test, what we do is we look at genes that are associated with how hormones are created within the body. And so we're talking sex steroid hormones, so specifically estrogen. Coupled to that, we also look at how it's cleared out, okay? And there's a few genes that will define how much you're making, how much hormone, how much estrogen you're going to be making. There's a few that will define what type, okay? And then lastly, there's a bunch that'll define how well do you get rid of it. There's a balance there, right? We'll never say, oh, it's one gene that does all of this. It's a balance of different systems, okay? And so if you are someone with the proverbial stars that have aligned to creating a lot of estrogen, and a form of estrogen that is more inflammatory, Inflammatory meaning, as it's broken down, as it's made, it's not necessarily creating good outcomes of estrogen, right? Estrogen can be a really good thing. It's more creating inflammatory, it's bothering the system, it's creating damage within some cells, right? And especially if you're not cleaning that up well, right? You're not repairing, you're not cleaning that up, right? That can lend to an environment that primes one for cancer, right? In particular, hormone related, so that's breast, uterine, ovary, etc. Okay. And so it's not a statement of that will guarantee, right? Estrogen toxicity, if you have a report that says you're prone to estrogen toxicity, that does not mean cancer diagnosis. What that does mean, though, is an increase of risk factor. So we have to look at all the other things that are going on, right? So this is where we look at family history. This is where we look at environmental toxin exposure, right? Are you drinking from glass or are you drinking from squishy plastics, right? This is where we ask the question of what's the stress going on? What is your diet like, right? Because it's not inflammatory estrogens alone. They're a huge contributing factor. I'm not going to deny that, but we have to look at what encourages that. How are you cleaning them up? And what's gone on, like what sort of hormonal birth controls, et cetera, have you been on? Have you given birth? There's a lot of different things that will lend into that picture. And so I would say I like the question of estrogen toxicity because it's important. It's a big contributing factor, but it does not sit alone. And so where the power of the DNA 360 comes in, or at least knowing your genes, knowing your history, is what other things are watering that? What other things in your genes and your lifestyle are watering the weed that can be inflammatory estrogens? And there's a lot that can be done, diet, lifestyle, supplements, etc. There's a lot that can be done to shift what sort of estrogens you're making and how you're clearing them. Yeah, I like that question.
Gotcha.
Thank you.
So another one is there's concern in the past year about glutathione for cancer patients, past or present. So what's your group's view on it? I think the first and most important thing is our group doesn't necessarily have a view. Each of the practitioners, comes from their own basis. What do you think about glutathione for cancer patients?
So I would dip a little bit into the genes and into what else is going on. So glutathione is this amazing antioxidant, right? It helps clean up a lot of stuff. And so the question is, how is that going to be used? Do you have capacity to use it? So a suite of genes that we look at are the suite called the GST. GST stands for glutathione S-transferase. So this suite of genes, this family, is not responsible for making glutathione. It's actually responsible for taking glutathione and attaching it to whatever the body's trying to clear out, often oxidants, heavy metals, other sorts of things, not endocrine disruptors, things that, like, from an immune perspective, like mold spores, all that fun stuff. It looks at how do you attach to that, okay? So if you're a poor attacher, right, that suite of family is not strong, regardless how much glutathione you give a person, right, it's not going to attach properly. It really can't do anything. It can sit out there, it can hang out, but it's not going to attach to what you want it to be attaching to. Now, especially if you're taking a lot of glutathione supplemental and it has nowhere to be attached to, I said this is the strongest and amongst the strongest antioxidants in the body. So the question is, what is this exceptionally strong? Think of it like a magnet. What is this magnet going to do in the body if it can't magnetize to toxins? What it does often is it will go into a part of your cell called the mitochondria. We all know the mitochondria is something that supports energy. It's something that supports the immune system. So what that magnet, that glutathione magnet, does is it goes in and it disrupts the activity of the mitochondria. The mitochondria, to offer energy, to offer immune system direction, needs to play with a bunch of magnets. So if you bring a super magnet in, you're going to disrupt that. That impacts energy, that impacts healing, that impacts the immune system, that impacts just this beautiful, glorious little complicated cascade of what the mitochondria feeds into, what its energy feeds into. Okay, so I would offer it's a very personalized response. And I would say it really would require clinical intake, both of genes and other things that are going on, other medications, et cetera. I would say the answer, if I was in that scenario compared to Dr. Steph in that scenario, it would differ based on our bodies. There's not one answer. And this is the tricky of personalized medicine, right? This is why that care team that has full perspective and humility in the sense of I know this, but not that. So let's talk to someone else if they don't know that. That's why it becomes so very important.
And that's why this becomes personalized medicine, because yes, it's something that's great. And yes, in general, it makes sense. But the problem has been if your traditional practitioner doesn't even know about a GSTT or a GSTM or, and then you start saying, well, yeah, but what if it disrupts all of the mitochondria? They're like, huh? So you can see why Dr. Krista is our scientific officer, because she not only understands the clinical relevance, but she also understands the science. And she is so phenomenal with continuing to dig in to that part of our DNA and then sharing it with all the practitioners so that we can maximize and offer the very best sets of information so you can make the best choice for yourself. Yeah. And then our last question is Francine, who said, I apparently had no lung cancer risks. I took lung cancer awareness tests and was asymptomatic, and yet was diagnosed with a stage 3A NSL-CLC 4 years ago at age 83. What could I have done to prevent this and been diagnosed earlier? So there's a lot to that, but the bottom line is this is where liquid biopsy is a perfect fit, where you have all the other traditional things done, and at this point liquid biopsy would have given you the heads up that says it looks like we're going down this path. And again, like we talked about with my client yesterday, lung cancer is not one that is traditionally tested for, so that would have been a heads up. So that's a perfect place where liquid biopsy could have been done.
Unless you have that history of smoking, there's not really that proactive testing. And we know that smoking is not the only cause of lung cancer. Is it a major one? Yeah, but it's not the only one. And so it's tricky when medical science reduces it down to this one thing, as that's the only candidate. A smoker is the only candidate for this sort of screening. So yeah, I agree.
Yeah. So Ardesh asked one final question, and then we'll wrap up tonight about, do we test for chronic pain through DNA? And my gut reaction would be no. However, chronic pain can either be inflammatory pathways, nerve tissues, and in that case, yes, because we do a lot with detox and with inflammation. But there's also the physical, if something's been crushed and impinged. So I think it depends on what you mean for chronic pain. I have several people who have daily chronic pain. They get out of their chronic pain because we reduce the inflammation in their body. But as far as a specific, do we test for DNA with or chronic pain within our DNA? My answer would be no. Krista, do you have any other?
That's correct. So firstly, we don't really do disease defining genes, and I think also medicine in general is kind of stepping away from that. It's very rare that you'll find a singular gene that's responsible for an entire pathology. And I would offer with chronic pain, there's many things, just like cancer, there's many things feeding into that. And so can we lay context and be exceptionally supportive in that instance? Absolutely. Because I think to Dr. Steph's point, right, we can evaluate what is contributing to that. And then I think also too, be it natural supports, be it cleaning up the body, be it pharmaceuticals, whatever that plan is for you, we have ways to kind of offer insight into what are the options and how can you go about approaching this pain? How can we reduce
So
it?
the follow-up on that is genes for pain tolerance. The neurotransmitters that would work with your ability to tolerate, your ability to manage, your ability to find joy and pleasure versus that constantly being squashed. Those we do, and that goes into mood and some people say I have a very high pain tolerance and it's how their brain perceives things. We do that in our basic Gene 360. And we will go through that in our mood and behavior section. And that really helps people understand that, also when we can get them detoxifying when they weren't detoxifying before, that really helps with pain. So it's, you know, Western medicine likes to put things in boxes, and we're like one of those skeleton watches that you can see through and all the cogs work together, you know?
Favorite.
I know they're my favorite too, because really the body, all the systems are impacted at all the time. And it goes back to what we were talking about, side effects. Just because something targets one system doesn't mean all the others aren't touched by it. Here's something fun, and this will be the last thing that I'll close with. If you want to know how much your body is touched or by everything, and everything touches everything, take a raw piece of garlic
Oh, I
and
love this.
rub
I
it
did this
on
when
the
you told me.
bottom of your foot and see how long it takes before you can taste it in your mouth. And you will realize that everything you touch, whether it's dirt, whether it's bleach, whether it's your hand soap, whether it's your perfume, how that gets in all your body systems and has touched everything. You know, some people do it with lemon, some people do it with garlic. I think raw garlic is awesome because, you know, you do it and then within 10 to 30 seconds, it's like, why do I taste garlic on my tongue when it came from the bottom of my foot? So everything impacts everything. And we just feel really blessed to have that peek behind the window, peek behind the curtain, to be able to share that with you so you have a better insight on you. And we appreciate everybody who stayed tonight and everybody who took that insight and will take it back to your loved ones, to your family, to your patients, because it makes such a difference. You know, science continues to evolve, especially good science, and science that asks, what are we doing right? What are we doing wrong? What can we do better? And that's what we should live by here at the DNA Company. Dr. Krista?
Oh, I think that's a beautiful way to wrap it up. And honoring of what fuels us, the science, and then what brings us here is the application thereof, right? Science is, as much as I would love to get lost in a cave of science and sit with it every single day, it's all for none if you're not using it for the better. And we're able to use it here for the better by supporting people's health. And so I think
You're welcome to all of you. And they will be sending out the link for everybody who joined us tonight, everybody that registered and wasn't able to join us, so that we can go back through those insights. You can watch it as many times as you want. Please send us feedback on what worked for you and what would you like to see. And I know we had a meeting today and they are putting out our calendars and filling it up with things that you want to see. So the more feedback you can give us on the things that you want to learn about, the things you want to see. I love that this is educational and you can take those insights, because if we have an insight and you have an insight and you share it, you know, we can change the world. You know, one person alone may not feel like they make a difference, but when all of us together start impacting 1, 2, 3, 4, 5, we can change the world and we can make it a healthier, happier place. And we're glad you're here. Thanks so much. God bless you all.
Au revoir.
Au revoir.